Good morning from Korea. This is, I have with me Dr. Jeff Winterstein, a fantastic internist with special focus on diabetes, practicing in Edmonton, Canada.
And good morning, everybody from South Korea. And I'm here with the noted endocrinologist Akshay Jain, who's been practiced in India and Bombay and is now the go-to endocrinologist in Surrey, British Columbia.
And we're very excited to talk to you about what's latest and greatest in the field of diabetes. In particular, two of the newest classes of agents that have come out, SGLT2s and GLP-1 agents. And Jeff, tell me more, has your practice changed after the Credence trial came out?
You know, my practice in particular, not really.
Mm-hmm.
I was, I think, amongst a few specialists already prescribing SGLT2s to patients who had compromised GFRs. So Credence was a bit of a relief for me. But you know, if you think of the physiology of the drug and how it works, the nephroprotection is almost far be gone, right? It's almost, you could almost predict what it would be, and you could also almost predict the improvement in glycosuria as well.
Absolutely. And for me as well, it's been a shot in the arm. For the longest time, we had absolutely no agents to take care of our renally impaired patients. And now we have something that's really helping us out. At IDF, in particular, we saw some newer analysis with the Credence data that showed that patients with a lowish lowish A1C, less than 7%, did not have the same degree of nephroprotection as those, say, with a starting A1C that was higher.
Now, did that surprise you at all?
It did, actually, because I felt that this was going to be, independent of the glycemic control. And certainly what the study showed was that with eGFR less than 30, the A1C reduction was only 0.15%, which we see very fairly regularly. But this was not something that I would have anticipated.
Yeah, I totally agree. And this maybe even has some forewarning for the future trials that are coming out in renally impaired patients without diabetes. Now we know DAPA-HF came out, and we saw benefit both in patients with and without diabetes with regards to heart failure. Can that be brought on to kidney failure, I think? I don't know now, eh?
Yeah, only time will tell us, right?
Yeah, it'd be very interesting to see that one. But, you know, familiar with the DAPA-HF story, that was their big trial, and that now we know that these drugs are across the board really good for your, they give you nephroprotection and cardioprotection.
Absolutely. We are now in an age where even before endocrinologists or internists get a chance to initiate these agents, it'll be done so by a cardiologist, a nephrologist, who knows who else.
Yeah, we're going to have to wrestle these drugs away from cardiology and perhaps nephrology as well.
Absolutely.
But we'll all have to act as one happy family, and all three of us will have to use these drugs.
So moving forward, and when we speak about GLP-1s, in India now the uptake is now building up with GLP-1s as well. And what do you think about the current usage of GLP-1s vis-a-vis their efficacy and their safety?
So, we have the whole spectrum of GLP-1s in Canada, and I'm not so sure that's across the world. So you have the twice dailies, you have the once dailies, and you have the once weeklies. And the once weeklies are showing some real good promise in terms of reducing cardiovascular mortality from their reducing stroke and their nephroprotection and reducing the ACR, albumin to creatinine ratio. So we're showing real good safety with those, and the efficacy, as you mentioned, is phenomenal. I think semaglutide is one of the most potent molecules second to insulin that we have out there.
Absolutely. And in fact, we're presenting data that we have done in Vancouver that shows that when patients are switched from liraglutide or dulaglutide to semaglutide, there is a further A1C reduction, often to the tune of 1.3% more than what we would have seen with the other GLP-1s.
Yeah. I'm finding that in my practice as well. Are you?
Yeah, totally. But what's very interesting is there's still a very big injection stigma in India, and now with oral semaglutide coming out, do you think that's going to change
right
clinical practice?
So that's the question, right? So oral semaglutide is coming out, and it may be designed for patients that don't want to inject. However, I don't know what the uptake is going to be beyond those patients. There's a timed process, right, with that, and you have to take it with a certain amount of water, and you do have GI intolerability as well. I'm also not sold on the efficacy of oral semaglutide. If you look at some of the pioneer studies, the middle dose of oral semaglutide is almost as efficacious as a DPP-4 inhibitor, and a DPP-4 inhibitor doesn't have the side effects.
You're right.
So you either have to go all or nothing on this one.
Yep.
And when you do go all, I think it does have the great weight reduction that we see with the once weekly semaglutide. But again, if you can't tolerate the high-end dose, is it something that you see yourself prescribing?
Well, the thing with oral semaglutide is that it requires the patient to take it in a very specific manner. So if they do not wait for 30 minutes after taking the medication on an empty stomach, then you may not get the same degree of A1C reduction that these clinical trials have shown.
Yeah, absolutely. And the big elephant in the room is what happens if you're in Synthroid, right?
Yeah.
Or thyroid medication,
Exactly.
which also has to be timed with other medication. You could be just totally regimented in the morning. So we're looking at something that could potentially be a problem. And I think when you're looking down the line and you're looking at the new GLP-GIP combination that is on the horizon, is semaglutide both oral and injectable? Is it time limited?
Oh, with every new agent that comes out, the older agents suddenly become obsolete all over. And then the data is looking so much better with the triagonists and the other newer stuff that we'll see. Speaking of newer stuff, just to quickly wind up here, is at IDF, we've seen that there's some fantastic nephroprotection data that's now coming out with newer mineralocorticoid receptor antagonists. So there is esaxerenone developed in Japan, and another one called fibranolone, which are non-steroidal MRAs, and these show reduction of microalbuminuria by a fifth, which is really good, without the same tendency to develop hyperkalemia that you would with spironolactone.
And they both seem to roll off your tongue very easily.
Yeah,
so they have to be good for you.
Well, that's it from Jeff and I from Busan in Korea, and hope we'll get to see even more exciting data the remainder of IDF.
Thank you for your time.